Hello, my name is Carolina Varela. I am a physician at the Quality of Care Unit at the Hospital Universitario de Octubre in Madrid, Spain. I am as well member of two scientific societies, the Spanish Society and the Madrilenian Association of Quality of Care. Thanks for watching. It is a pleasure for me to introduce you to this work titled An Expert Consensus Delphi Study in Practical Considerations for Implementing Health Outcome Measurement Projects in a Healthcare Organization. Implementing value-based healthcare requires incorporating the measurement of health outcomes and cost per patient. As it has been formulated, it implies change in the current paradigm of healthcare with a redirection of the objectives of the institutions toward the participation of the patient in the care process with co-responsibility and shared decision-making, as well as of the methods of payment to providers toward payment by results. It therefore involves a profound cultural and organizational transformation that is not without its difficulties and funding requirements. Methodological support and monitoring the quality and governance are clear needs in the healthcare organization seeking to incorporate these aspects into routine healthcare. So, as a methodological aid of the project, the Quality of Care Unit launched a Delphi study. The study was carried out using the two-round modified Delphi method with a multidisciplinary expert panel of healthcare professionals, quality, clinical management, and innovation methodologists, and managers with academic and practical experience in outcome measurement projects. A total of 20 competencies were considered, as shown in the figure upper part, as a selection criteria, each of them represented by at least 3 experts in the first round. And we also aim to include different professional areas of the health sector, meaning professional scopes, as in the bottom area, in the bottom part of the figure is shown: healthcare institution, academic fields, pharmaceutical industry, or government agency. You can check the 20 competencies that go from informatics to clinical experience or quality of care management. We had a total of 38 experts initially selected for the first round, and the second round the first round was finally complete by 34, and the second round was complete by 28 experts. The Delphi questionnaire was developed by the Quality of Care Unit of the Hospital Universitario de Octubre, based on the experience accumulated over the last 3 years. The previous last 3 years of coordinating and managing 4 health outcome measurement projects. It was structured into parts with 13 questions in total and 82 items to be evaluated on a Likert scale from 0 to 5, with being 0 not at all important and 5 very important. In the first part, the expert will ask about the factors that should be taken into account to evaluate the complexity and feasibility of a performance measurement project, and in the second part, about the technical packages and activities necessary for the execution and implementation of this type of projects. The consensus criteria were that there should be a median equal to or greater than 4 and a relative interquartile range equal to or less than 25%. The interquartile range tells you the spread of the middle half of your distribution, and is a measure of the distribution of the data. Okay, the tool used to distribute the questionnaire among the panel of participants was the Google form, with a glossary of definition of concepts attached to facilitate understanding of the questions. Each expert completed the questionnaire individually without interacting with the other experts. To avoid biases in the results, the coordinator responsible for preparing the questionnaire did not respond to it. The consensus was obtained in 90.82% of the items, 74 out of 82. with respect of the feasibility, the highest scoring and consensus, as shown in the bottom part of the of the figure, excuse me, the upper part shows the project technical packages phases. This has been explained in a couple of posters that we have already in the meeting, so I invite you to check these other posters that are you can check them in the same link as we give you for this poster. So with respect to the feasibility in the bottom part of the figure, the highest scoring and consensus items were existence of data protection guarantees with a median of 5, a mean of 4.8, an interquartile range of 0%, vision and motivation of the professionals with a median of 5, mean 4.7, interquartile range of 20%, existence and availability of the tools for data recording, median for 5, mean 4.5, interquartile range of 20%, and sufficient funding, median 5, mean 4.2, and interquartile range of 20%. Based on this result of the Delphi study and several semi-structured interviews, we developed a series of tools to implement for implementation as an implementation aid, and we wanted to introduce here two of them: the feasibility decision aid, weighted checklist to prioritize concurrent proposals, and the complexity estimation tool, healthcare process complexity score for resource allocation. As you can see, the project complexity drivers were several. The complexity drivers were all of this. I'm not going to go into detail. You have this information available if you care to have a look, but they all have a consensus of the experts. They range from the number of care levels involved, is primary care also involved, or is only hospital care, the number of patients, the number of questionnaires that you have to validate or are already validated, but you have to pass to your patients, or if you really know your process and you have a flow chart already existing in the service. So these factors adding complexity, the factors adding complexity more highly rated were number of integrations between different databases with a mean of 5, a median of 5, a mean of 4.5, and an interquartile range of 20. Involvement of various levels of care with a median of 5, mean of 4.4, and an interquartile range of 20. That there is an accepted set of monitoring indicators for the condition under the consideration. If this the data set exists, had a median of 5, mean of 4.4, and an interquartile range of 20. And the number of units or services involved in the process, in the healthcare process, had a median of 5, a mean of 4.4, and an interquartile range of 20%. Practical aspects for incorporating excuse me, value-based healthcare into routine clinical practice were described, and we thought that this could serve as a tool for prioritization, sizing, resource planning, and estimation of the implementation cost. So to do so, I will show you the draft of these two tools that we have developed and that we are on our way to validate them. And if any of you are interested in using them and help us with the validation, you feel free to contact me. Okay, here you have the feasibility constraints and the answers you have for these constraints and the punctuation that will give you a punctuation that will rate your project as very feasible, not much feasible, or not feasible at all. There are some information or some items that are must-have, like there are data protection warrants. Yes, okay, you can do it. No, you cannot do the project. You need to have this protection of the data. No, the financing. Well, if you don't have funding, it's gonna be difficult to do the project, but probably not impossible. So you can you can try it if you have the internal resources. So I'm not going to go deep in this table because you have the information and I am open to any question, but I will say that the lack of vision or motivation of the clinician team is a great impediment for the project success and would be unadvisable to begin with the project at that moment. If you don't have this motivation of the clinician team, if you don't have this clinician leader, this clinical leader, better don't begin with the project. As I explained, the data protection warrant is a must-have. Without this, the project is not legally or ethically possible to implement. And this is important because some people plan to do value-based healthcare without measuring costs. But if you don't measure cost, you cannot calculate value. So you are not really doing value-based healthcare. So you have to measure cost. The project can't be developed, or the project can be developed, but the efficiency or the value add per monetary unit cannot be calculated. You can only talk about health outcomes, and therefore technically it's not possible to calculate value as defined by Porter in 2010. And the ethics committee is the ethics committee is a good point because a lot of people think that it's a paramount to have the ethics committee approval, but these are projects for healthcare improvement and they don't really change the healthcare. They only do it in a different way. So in theory, they don't need this approval from the ethics committee. However, we think it's advisable. Even if the project does not involve any clinical intervention, the committee should review the working protocol. The incorporation of PROM and PREN does not necessarily require patients' informed consent, but it would be nice to have an evaluation, external evaluation from the ethics committee to see if it can harm in any way the patients. And also, and this is a side effect, it's good to have this evaluation for any future publication on the secondary data. The punctuation proposed in both in this tool and in the next tool I'm going to explain is based on the relative importance given by the expert, but not has been yet, as I explained, been validated. And this is the tool that evaluates complexity. The higher the complexity, the more resources you have to allocate to the project. And the higher complexity and higher and lower feasibility, it would mean that the project is not really easy to develop. So we have developed a tool to estimate the complexity of the healthcare process with the idea that it would help to improper resource allocation. We are not explaining the table in detail. You can have this information available if you care to follow the link on the video description, but it includes a number of questionnaires to apply to the level of care participating of the project, of the process, sorry. As I explained before, the punctuation proposed is based on the relative importance given by the expert, but has not yet been validated. What we have established is like 3 levels that multiply by 0 or by 5 or by 10, depending on the answer you give to the different factors increasing complexity. The higher the level, the higher the complexity, and the more difficult the project is. So as I keep saying, we are at your service. I leave there my contact information. If you feel like giving feedback or asking questions, you can either write to me or leave a comment on the video. There are several people related to this work that would be very happy to answer your question, including me, of course. In the video description, you have a link with a PDF of the poster, the abstract sent to the meeting, and some articles regarding the issue. We do appreciate your interest, and remember, as Avedis Donamedian used to say, the ultimate secret of quality is love. Thank you very much for watching, and see you soon. Excuse me, see you soon.